So I will be talking today about current and emergent treatment options in neuromyelitis optica spectrum disorders. I just need to put those disclosures on slide, and also this disclaimer that the content presented at this presentation does not constitute any express or implied endorsement of any particular product or service. We need to be compliant with policies. I'm going to talk about briefly what is NMO, NMOSD, how we treat NMO, NMOSD relapse, what we have currently available as a treatment option for NMOSD, and what are emergent treatments. What are the treatments possibly that will come in the near future? So what is NMO or NMOSD? It is an autoimmune, inflammatory, and demyelinating disease of the central nervous system. We say autoimmune because it's immune-mediated, where the immune system turns against person's own. If we say it's inflammatory, because there is a lot of inflammation going on there that causes tissue damage. And we say that it's demyelinating because there is some degree of demyelination, which basically means the disruption of the insulating sheet that covers the nerves. And we say that it is a disease of the central nervous system that basically consists of the brain and spinal cord. And just as a reminder, optic nerve also belongs to the brain. So the disease course in neuromyelitis optica spectrum disorder, or NMOSD, in most people is so-called relapsing remitting. So what does that mean? That means that people may have the first attack. After that, they may get into the period of remission, which is a period of relative stability. And after a certain period of time, they may get another relapse. And we know that 90 to 95% of people who have NMOSD will have a relapsing remitting disease course. In about 5 to 10% of patients, the disease may be monophasic, but the term monophasic is actually time restricted. So we can say the person has been monophasic in 5 years, but we don't know it is going to be monophasic for the rest of the life. We have seen in the last decade that relapse rate, actually the frequency, how often the relapses come, has decreased with the treatments that we have now available. And actually the relapse rate decreased tenfold in the last 10 years. So like long time ago, around 2008 or 9, the annual relapse rate, meaning how many relapses people had per year, was about 1.5 per year. And now it's 10 times less. So now people with NMO get relapse once in 10 years or once in 15 years if they are treated. So that has been a great, we say, paradigm shift to the approach of recognizing NMO and what can NMO bring to the person. Most of people with neuromyelitis optica test positive for the antibody that is called NMO antibody or NMO IgG or aquaporin 4 antibody. This antibody targets the specific molecule that's called aquaporin 4 that is expressed in some cells in the brain that are called, and the spinal cord that are called astrocytes, but also on some other cells in the brain. This aquaporin 4 is also expressed in the optic nerve and also in some other tissue in the system, such as kidneys or guts. However, people with NMO don't get usually symptoms from the kidneys and guts because, or in muscles sometimes, because the molecular shape of the aquaporin 4 is different in muscle than in the brain, spinal cord, or the optic nerve. And this is how brain, spinal cord, and optic nerve aquaporin 4 can be easily targeted by the antibodies, whereas it's not easily targeted by antibodies if it's in the muscle or the kidneys. So this is how the aquaporin 4 molecule, sorry about this, looks like. And just to remind you what the antibodies are, those are Y-shaped proteins that basically are made by a subset of B cells that are called plasma cells, that basically everyone has antibodies in their system to protect from infections. However, sometimes in autoimmune diseases, the antibodies can turn against person's own tissues. So where is this antibody coming from? So we know that it is actually coming from the so-called peripheral lymphoid organs. Those are the lymph nodes and spleen, in which the B cells that make antibodies, that we call plasma cells, reside. So the plasma cells make antibodies, the antibodies go into the bloodstream, and they get bound to this aquaporin 4 molecule that is expressed on this nerve cell in the nervous system that we call astrocyte. And after that, that is bound, that may initiate a cascade of process that actually leads to tissue damage. So in addition to antibody binding to the aquaporin 4, there is a whole inflammatory cascade that brings more inflammatory cells to the central nervous system and then activates some proteins which are called complement, and then some of those cells make inflammatory mediators that are called cytokines and chemokines, and all those together cause tissue damage. And the tissue damage can happen in brain, spinal cord, or the eye nerves. And the tissue damage contains a lot of inflammation. There is a lot of swelling. The blood-brain barrier, which is the barrier in between the blood and the brain tissue, gets leaky. And then the leaky blood-brain barrier can actually help more antibodies to come into the brain, more inflammatory cells to come into the brain and the spinal cord and the eye nerve, which causes more and more tissue damage. And there is all that tissue damage leads to the nerve cell damage and to the myelin loss. As I said, the damage of the myelin sheath that covers the nerve cells. Among those cytokines, I would like to stress out, just remember this one, which is called interleukin-6. There are many that can play a role in the tissue damage, but this is of particular interest because we now have a specific drug that targets that loop and that pathway that is mediated by interleukin-6. So how do we make a diagnosis? The criteria for making the diagnosis of NMOSD have changed a lot over the last 20, 30 years. We currently use so-called 2015 NMO diagnostic criteria that basically provided a guide how to make a diagnosis of NMOSD in people who have positive tests for antibody against aquaporin 4, which is around 80%, and specific guide how to diagnose NMOSD in people who have negative tests for aquaporin 4 antibody. A lot of those people who test negative on the test for aquaporin 4 antibody actually at that time were discovered to have antibody against another protein which is called MOG, or myelin oligodendrocyte glycoprotein, which Dr. Donna Graves is going to talk about more after me. This criteria from 2015 actually make the diagnosis possible not only in people who have presentation with optic neuritis, inflammation of the optic nerve, or myelitis, which is the inflammation of the spinal cord, but also in people who have other clinical presentations outside of the optic nerve and the spinal cord. However, in 2023, we actually got a new diagnostic criteria to diagnose this separate disease that is called MOGAD, or myelin oligodendrocyte glycoprotein associated disease, which basically pulled away from the NMO umbrella and the NMO basket those people whose antibody test came positive for MOG antibody. So previously, people who had MOG antibody are considered to be in the basket of NMO, but now they are separated into separate disease category. So we now have a separate disease criteria to establish the diagnosis of MOGAD. And that actually requested and required the NMO criteria to change. So there is a process ongoing now that is actually aiming to establish new diagnostic criteria for NMOSD that are going to come out in early 2026, possibly. What is proposed currently, and we actually need to see how it is going to look at the end. But as for now, what has been proposed that only people who test positive for aquaporin 4 antibody will be called NMOSD, and NMOSD will not be abbreviation anymore for NMO spectrum disorders. It is going to be an abbreviation for neuromyelitis optica seropositive disease, which means only people who test positive for aquaporin 4 antibody or NMO IgG antibody will be called NMOSD. So what about those people who test negative for NMO antibody and they still test negative for MOG antibody? So that category will probably be called NMO-else, NMO-like syndrome, but this is still under discussion, how to call and what criteria would be to diagnose this group of patients who may clinically present as NMO, like have optic nerve damage and spinal cord damage or some other clinical presentations that look like NMOSD, but they test negative for NMO IgG or an aquaporin 4 antibody, and they test negative for MOG antibody. So more to come in the very near future. So how we treat relapses or disease attacks. I would like to stress out that the first important thing is to confirm the relapse. And why is that important? Because sometimes people with NMO can get so-called pseudo-relapses, which basically means worsening of pre-existing neurological symptoms in the setting of being stressed, overheated, having an infection, or maybe sometimes having not a good sleep. So the first step for you, if you suspect a new symptom or worsening symptom, is actually to reach out to your neurology provider so that they can see you as soon as possible, examine, do a neurological examination, and confirm the relapse. After we confirm the relapse, then we need to treat it, and actually we should treat it as soon as possible. The first line of treatment is actually high-dose steroids intravenously. And we usually do that over 3 to 7 days. In children, I put here the doses that we use in adults and children. In adults, we usually use 1 gram of Solumedrol per day. In children, we typically use this dose of 30 milligrams per kilogram per day, maximum of 1 gram per day. If a person with NMOSD has a moderate or severe relapse, they usually qualify for another procedure for relapse treatment that is very important in NMOSD, which is called plasma exchange, or PLEX. So what is PLEX? Plasma exchange is a procedure where basically the blood gets cleaned from the antibodies, from the inflammatory proteins and mediators, from activated complement, so that the whole inflammation may come down. In addition to treating relapses or flare-ups, it's very important and crucial in people with NMOSD to do the maintenance treatment. Why is that so important? Because in NMOSD, disability comes from relapses or disease attacks. When the relapse occurs, the recovery after relapse, after we treat the relapse, can be complete sometimes, but sometimes can be incomplete. And people may be left with a variable degree of neurological disability that will stay forever, permanently. But it's not going to get worse. And this is totally different than what we see in multiple sclerosis patients, which is another immune-mediated and demyelinating disease that is frequently mistaken for NMO. So in multiple sclerosis patients, after a certain period of years, the patient will start slowly getting worse and worse in some instances. And that doesn't happen in NMO. In NMO, if you prevent new relapse or new attack, people will not get new disability. So they will not slowly get worse over time. They may stay with what's left from the prior relapse, but if you don't get another relapse, there won't be any new disability. So this is how those two diseases that may look alike, symptom-wise, can actually be very different. So if we prevent successfully a new attack or relapses, then we don't expect new disability in our patients. So how do we choose maintenance treatment? It is a very complex process that we need to look at from different perspectives. So what we're looking into when we make a decision on a treatment, we look into patient-related factors, treatment-related factors, we look into disease-related factors, and system-related factors. So what are patient-related factors? We talk about patients, what is their preference? Do they want to get IV treatment or maybe injection treatment? Or some people prefer orals, and then we need to talk about oral off-label medications. What is the individual risk tolerance for everyone? What are the comorbidities or other diseases that the person may have in addition to having NMO? What are other medications that people are taking for different other conditions that they may have, like for high blood pressure, or cholesterol, or depression? What are the pregnancy plans and family planning? Treatment-related factors include our discussion on what is the expected drug efficacy, what do we expect from this drug, what are the safety issues that we need to think about, what is like tolerability, whether the patient has a high tolerance of having potentially some risk of side effects or not. What are the drug safety monitoring needs? Every drug that we use practically in neuroimmunology needs to have some safety monitoring. And later on in the afternoon sessions, you'll hear also from the pharmacist, our pharmacist, who is actively involved in the drug safety monitoring in our team. What is the frequency of drug administration? Do you want infusions to be given once in 6 months, or you want infusions or okay to be given every 2 weeks? Then we look into disease-related factors. As I said, is the person testing positive for aquaporin 4 antibody or not? What is the disease activity, meaning how often people get relapses? What are the potential prognostic factors in an individual patient? Does this patient maybe belong in a high risk of future relapses or a high risk of more severe relapses for some reasons? And what are the system-related factors such as access to medical care, insurance, and drug coverage? So what else we do? When we are considering all those factors, we actually need to make a decision that is specific for an individual patient. So this is why we use so-called individualized treatment approach, where we basically try to consider all those factors and make the best decision for this specific patient. In NMO treatment, there is no one-size-fits-all, so there is no first-line treatment that you need to go, and then if this fails, you go to the next level. No, we try to choose the best drug for each specific patient, and we do that through so-called shared decision-making process, which basically means we talk to the patient, we talk to their caregivers, and they talk to us, and then we make a treatment decision together. So what are the options that we can consider today? I listed here the list of currently available FDA-labeled medications, and it's not by any means in order of preference. It is in order how they were labeled by FDA. So in 2019, we actually got the first drug labeled for NMOSD, and that was a game changer at that time, and that was eculizumab or Soliris. And this is the drug that is given intravenously, and we give it weekly for 4 weeks, then 1 infusion at week 5, and then continue every 2 weeks. With this medication, we need to be cautious about the risk of so-called encapsulated bacteria, which is basically a type of bacteria or the group of bacteria that they have a kind of hard protective sheet to hide from the immune system. So this medication may have an increased risk of infections with this type of bacteria, and one of those bacteria are meningitis or meningococcal bacteria. And this is why we really need to be cautious and vaccinate our patients before they start on treatment with this medication. If we need to start the treatment with this medication before the person is vaccinated, then there is a protocol to prescribe prophylactic antibiotics, start the treatment when it's needed, and then when the person completes the vaccination, then antibiotics can be discontinued. And this is the way how we can manage the treatment with this medication when it's really needed without waiting the patient to get vaccinated. But really every patient who is undergoing treatment with this group of medications needs to be vaccinated against meningitis. The second drug that has been labeled in 2020 for NMO is so-called satralizumab or Enspryng, and it is a subcutaneous injection that is given on the day 0, basically, after 2 weeks at week 4, and then every 4 weeks. And this is something that the patient give themselves at home. We need to be cautious with this medication about the potential risk of hepatitis B reactivation or tuberculosis reactivation, and this is why we need to test for hepatitis B exposure and so-called latent tuberculosis, which is basically the situation where the tuberculosis bug is dormant in our system before we start the medication. There is a need to monitor liver enzymes, and also this medication can lead to the decrease in one type of the white blood cells. So we need to keep an eye on that before we start the patient on treatment and also after starting on a treatment. And the third drug that was labeled was Uplizna or inebilizumab that was labeled in 2020. It is an IV medication, so given intravenously. And it is given on day 1, day 15, and after that every 6 months. With this type of medicine, we need to be cautious about the potential risk of infections because this medication is immunosuppressant. It is going to put immune system down. We also need to be cautious about the potential risk of hepatitis B reactivation, and this is why we need to test the person for hepatitis B exposure before we start this treatment. And given immunosuppressive effect, we always advise our patients to be up to date on all the vaccines that are required per primary care physician recommendations. There is a potential risk of infusion reactions, which basically means during the infusion, some people can get like throat scratching or some itching or maybe some breathing difficulty or hives that usually require some additional management in order to complete the infusion. And usually those reactions are really mild. The last drug that came to the market was ravulizumab or Ultomiris, and it was labeled in 2024. This is the very similar medication to eculizumab. It works in a similar way, and it's given intravenously. The first infusion is given on day 0, basically. After that, the next one is after 2 weeks, and then every 8 weeks. The same precautions apply as if we were recommending eculizumab or Soliris. So all patients need to be vaccinated against meningitis. And if that is not possible at the time of treatment start, then provide antibiotic prevention until the person is vaccinated completely. So how those drugs work? I kind of prepared this to kind of make it more easier for you to understand. So I already said that the B cells are the ones that are making antibodies or plasma cells, a specific type of B cells. So what is inebilizumab doing is actually, it is a monoclonal antibody, which basically means specifically engineered antibody that targets a specific protein, and it targets the specific type of B cells that carry this marker, which is called CD19. And CD19 marker is not expressed on plasma cells, but it is expressed on all cells that are coming prior to plasma cell showing up. So if you use this antibody, then it is going to basically destroy all B cells that are supposed to convert into plasma cells. So over time, we won't be getting plasma cells to make antibodies. The other group of drugs, which are Soliris, eculizumab, and revolizumab, those are monoclonal antibodies that target specific complement component that is called C5. And as I said, complement is a kind of set of proteins that is very important to fight against infection. And during evolution, this is one of the oldest parts of the immune system. And it is very important to have complement. But sometimes complement can be causing damage if it gets activated in the wrong way. So those two drugs, eculizumab and revolizumab, block this C5 complement component, and then that prevents actually the killing strength of the complement that can destroy the cell. So if we block the complement, there will be less cell destruction in the brain and the spinal cord and the eye nerves. And we mentioned previously cytokines and chemokines, the inflammatory proteins that promote inflammation, and they boost the inflammation. It is a huge network, and there is a lot of crosstalk in between the cells and between those proteins. And one of the key players there is interleukin-6, which is a very important cytokine for the crosstalk in between so-called B cells and T cells. Those are two different types of immune cells. By blocking interleukin-6 pathways, we can actually slow down or stop the inflammation. So the satralizumab is a monoclonal antibody that blocks IL-6 receptor. But as you see, there are a lot of potential new targets that still haven't been targeted with the medications that we have available. So by the medications we have available now that I mentioned that are FDA labeled and approved, we can prevent some tissue damage and prevent new tissue damage that can happen with NMO relapses. What happens if the person cannot go on FDA-labeled medication for any reason? We see this scenario, for example, if the patient has comorbid conditions, meaning some other disease that is also autoimmune that needs to be treated in a different way. For example, the person with NMO can often have other autoimmune conditions such as lupus or rheumatoid arthritis or Sjogren's disease, for example. And then rheumatologist wants to use rituximab to treat rheumatoid arthritis, and then there is doesn't make sense if the rheumatoid arthritis is beneficial if rituximab is beneficial for rheumatoid arthritis, it doesn't make sense for us to recommend separate drug for NMO because we know that rituximab can be also potentially beneficial for NMO treatment. So this is a kind of scenario where we nowadays may still be using so-called off-label medications. And there are also patients who have been started on those treatments before the FDA-labeled drugs came to the market. And if that approach keeps the disease control at the desired level, then it really, patients are usually not willing to change it because you don't fix what's not broken, correct? So, so we still have some patients who are treated with rituximab. Rituximab is an IV medication. It is not labeled in US, but it is it is labeled in Japan, for example, for NMO. So, and it's, we have two regimens. One is once weekly for 4 weeks, after that every 6 months, and the other is day 1, day 15, and after that every 6 months. And with rituximab, we also have, because it's an immunosuppressant, it pulls the immune system down, we have the risk of somewhat increased risk of infections, and we always need to recommend our patients to please stay up to date with all the vaccines that are required per health maintenance. We still have patients who may be treated with mycophenolate mofetil or mycophenolic acid or with azathioprine, which are oral medications, oral immunosuppressants. And usually those patients are the ones who also have other comorbid conditions treated with those medications, and they may work for NMO as well. And we, of course, use steroids. We try to use steroids as little as possible because of the potential side effects, which are well known: diabetes, hypertension, glaucoma, cataract, acne, insomnia, mood disturbances, weight gain. But sometimes steroids are really needed. And sometimes we can combine using steroids in a certain dose with other FDA-approved or other off-label medications, if this is needed to keep good disease control. I want you to remember that NMOSD maintenance treatment is, per current recommendation, need to be given lifelong. So we need to treat our NMO patients lifelong, because you never know, even though we say, yes, relapses on average statistically come once in 10 years. In some people that may be less than that, or more frequent. So, and sometimes in NMO relapses or attacks can be very devastating. Sometimes we know that some people may get into coma, for example, from the bad NMO relapse. So because of potentially devastating relapses that may come in the future, the treatment of NMOSD is maintenance treatment needs to be lifelong. And we don't know when those attacks will come. Hopefully never, if we treat the disease well. But even if we do our best, sometimes the disease can be very active. When we start on treatment, sometimes we need to change the treatment. So we start with one medicine and we need to change it. So why we need to change it? Because of different reasons. Because there is a new relapse or breakthrough disease, what we call. So basically, you start a patient on some treatment, they have a new relapse. This is when we need to discuss with our patient, should we change the approach and maybe change the medicine to something that works in a different way. We change medications because of potential drug side effects. So if the person has started on some treatment and they have some side effects that cannot be tolerated by the person or by the provider, the providers also have some tolerance level. So we can recommend switching treatment, or the patient can request switching treatment. And we change treatments if there is we see that the infection rate is increasing maybe, then we may want to do something that may not be affecting infection risk so much. And we also can have discussion about changing treatment approach during pregnancy, but you'll hear more about from Dr. Sach today in the afternoon session. So what are the new players on the horizon? So currently we have more than 60 research projects and trials that are actually looking into potential new drug targets for the drugs that may be working in a different way, maybe be more safe, looking into how those drugs work in adult population, in pediatric population, and in some special populations, such as, for example, pregnant women. The new potential approaches is looking into new complement inhibitors. So we already mentioned the complement role in NMO. So there may be some new complement inhibitors coming. Then new generation of the drugs that kill B cells. Then this class of the medications that is called Bruton's tyrosine kinase, or BTK inhibitors. Those are the medicines that actually don't kill B cells, but they can block the activation of the B cells so that B cells don't get overactive. In addition, this type of medicine is now in development also for multiple sclerosis. They can also target another type of cells that is called microglial cells, and the microglial cells are the ones, are among the cells that can make those cytokines. And for example, they can also make multiple cytokines, including that interleukin-6 that I already mentioned. There is another class of medications that are now in use for some other neurological diseases, and then they are called NFCR inhibitors, which basically block so-called neonatal Fc receptor that is basically an immune receptor that if blocked, can speed up antibody clearance from the system. So if we block this receptor, then we can have antibody against aquaporin 4 cleared up in a natural way faster than usual. Then another class of drug that is called Janus kinase or JAK-STAT inhibitors. This is the key signaling route for many cytokines to talk to each other and to affect how the cells work. So if you block that, we may slow down the inflammation. There are another class of cells that are called NK cells. Those are one of the inflammatory cells. It is a specific kind of inflammatory cells, and blocking those can also slow down the inflammation. There are T cell inhibitors in development that can block the T cells, the specific type of immune cells that is called T cell. Then there are some specific drugs in development that can block this protein that is called B cell activating factor, or BAF, that can actually block the activation of the B cell. So the B cell, again, may not get activated to cause the damage and produce abnormal antibodies. And there is a huge line of research in so-called CAR-T therapies, which is basically engineering T cell to go and attack some other immune cells and put them down. So the way it works is basically person's T cells is taken from the person's blood. It gets nourished and engineered in a way that it's strengthened up and then put back to the person's system so that it can act on, for example, B cells that cause inflammation in NMO. And that is a novel line of research, not only in NMO, but also in some other autoimmune diseases. And also we have some so-called bispecific monoclonal antibodies where there are engineering antibodies that can block not only one protein, but two. And in that way, it can work in two different ways to maybe have a more effective medication that will put the inflammation down. And there is also something that is called immunotolerance, which is basically building up the immune system to not self-attack, but to build up the tolerance. This is working in a similar way, like when you're getting allergy shots. And this is a very, due to time constraints, I don't have enough time to go into details about this, but I'm happy to answer questions later on. So just wanted to kind of close with the message that we have a very good treatment options today that have changed the NMO prognosis a lot. In 1999, mortality rate from NMO when we didn't have those medications was 30% in 5 years. Today, with all these medications, mortality rate is between 2 and 9%. So that is a huge change. And maybe with new medications that are on the horizon, we'll have even much more improvement in terms of reducing the mortality rate, improving disability level, and improving prognosis in our patients. And thank you so much for your attention.